Monica Luke. Monica is a mental health advocate focusing on financial barriers to accessing mental health care. Her activities include legislative advocacy, parity enforcement, and creative approaches to expanding payment models and commercial insurance coverage. She works on the MapNet Financing Subcommittee and partners with the National PEP Network Group. Monica is on the Strategic Steering Committee for Core Mental Health, a nonprofit focused on racial equity and mental health, and is a consultant with the Massachusetts Association for Mental Health and co-chair of the Massachusetts Mental Health Coalition. In 2023, Monica joined Health Law Advocates as a part-time paralegal focusing on parity issues. She recently concluded 6 years of service on the NAMI Massachusetts Board of Directors. Passionate about social justice, Monica recently concluded a term as a racial social justice ambassador for the city of Somerville and currently volunteers with the Wellesley Racial Justice Initiative. Previously, Monica worked in the technology sector for over 20 years, including as a technology executive at IBM. Leveraging this long career in technology, she routinely mentors and supports entrepreneurs building mental health apps. Monica has a degree in computer science from Wellesley College and is a graduate of the Gender, Leadership, and Public Policy program at UMass Boston. Next, we have Scott Beardsley, PhD, Vice President at Optum. During his tenure at Optum Behavioral Health, Scott has overseen a national quality improvement program. His primary responsibilities have been overseeing accreditation compliance for several large service centers, directing quality improvement activities, increasing adherence to evidence-based practice, and maintaining a robust quality improvement program. Scott completed his PhD in clinical psychology at Emory University and has worked as a licensed psychologist in both the public and private sectors, serving a diverse population of high-risk patients. He also has over 20 years of experience as an executive in managed behavioral healthcare organizations, as a clinical researcher, supervisor, and quality improvement executive. And last but not least, we have Dr. David Shern, PhD, who served as the president and CEO of Mental Health America from 2006 to 2012. After leaving MHA, he joined the staff of the National Association of State Mental Health Program Directors as a senior public health director. He also has an appointment in the Department of Mental Health at the Bloomberg School of Public Health at Johns Hopkins University. His work has spanned a variety of mental health services, research topics too numerous to mention. Recently, he has been focusing on the implementation of coordinated specialty care for first episode psychosis and leads the Stanford PepNet Finance Work Group driving payment options nationwide. The title of their presentation is One Code to Unite Them All, Billing for Psychosis Care. Over to you guys.
Thanks very much, Dos, for that amazing set of introductions. I'd have shortened mine if I'd known you were going to be reading it. And thank you so much, Scott and David, for joining me on this panel. For those who haven't talked to us, we're going to do this as like a panel. We're going to mostly be chatting with each other, but we'll start a little bit with sort of why we're here, why the three of us are on this panel together. As Dos mentioned, I'm on the finance subcommittee for MapNet, and one of the things we've been working on over the last couple of years is how to get coordinated specialty care covered by commercial insurance here in the Commonwealth. And both David and Scott have been amazing advocates in that space nationally in both cases, but also in Scott's case here in the Commonwealth. So we're excited to share with you all the new things. And one of the things I said to a group of people yesterday is, we don't have to take piecemeal payment anymore for coordinated specialty care. If you step away from this panel with one thought, it's you can be reimbursed with a team-based rate for coordinated specialty care that covers everything that you do as part of coordinated specialty care. So that is exciting, and there's a lot of component pieces that go with that. So David, let's start with you and explain PepNet and how you drove to a successful conclusion of getting a national billing code for coordinated specialty care.
Well, first and foremost, that I did it with all of my colleagues, including Monica and Scott and many others I can see Margaret's on the call, but the number of boxes that I can see are quite limited. So PEPNET actually started at the end of what was called the EDAPT trials, and those were trials that were financed by Robert Wood Johnson, looking actually at what we now would call chronic people who were at chronic high risk. There was some funds left over from that RWJ project, and they were used to start this PEPNET program at Stanford, which has now become sort of the mothership for several different activities, one of which is this financing group. The financing group actually, Monica, began in 2019. It's hard to believe how time has gone by. We had a meeting in December right before COVID enriched all of our lives. It was kind of the last face-to-face meeting I think I'd had for probably 4 years. And we learned then that Illinois had passed this statute requiring commercial payers to pay a team-based rate for coordinated specialty care. And the group was very excited by this possibility and decided to form an ongoing financing group that has met monthly since then. And it's instructive that what this has sort of morphed into is kind of a learning community uh, focusing on various state efforts to implement a comprehensive reimbursement system for people with early onset psychosis, looking really first and most intensely at Illinois as the Thresholds program in Illinois worked to implement this rate. And Scott's going to talk a little bit because he was on one of the two commercial payers who first negotiated a team-based rate with Optum. But what we learned in conducting the group, Monica, was that there were several efforts ongoing around the country. Washington State, in their Medicaid program, was working to establish a team-based rate, which has now been established. New York State, we learned just recently, has had CMS approve their team-based rate, among several other states working on this. And so this is kind of our laboratory. The PEPNET group is kind of our laboratory to observe what's going on and to learn things like you can't call it a bundled rate, you can't reference programs, all of this sort of word magic that goes on in terms of working with CMS. Now, as we started the royal we, this is our colleague Ron Lambert at Threshold, started to negotiate with the Blue Cross and Blue Shield and Optum in Illinois, we discovered that the code that had been used had been suggested to be used for coordinated specialty care was actually used for other services in these two payers. And we therefore decided to go boldly where I had never gone before, and that's to CMS to see if we could get them to approve a code for coordinated specialty care. And it was about a year-long process. Our good colleague Brenda Jackson, who knows everything there is to know about Medicaid financing, Ken Farbstein, who's part of your group, who I understand is celebrating his 45th college reunion, and I don't think he's with us today. He's going to miss the next meeting he ordinarily attends. We're sort of the dynamic trio that put together the application. We got tremendous support, which was championed by Ken, so that we had the former director of CMS, who Ken happened to know, the former NIMH director, and a sort of a cast of thousands supporting the application, including the Assistant Secretary for Mental Health and Substance Use, Miriam Delphin-Rittman. We went through the process. We went to the hearing, and Scott participated in the CMS open hearing where they got to question us about why we needed this code, and subsequently in October of 2023, amazingly a year ago, as we come into fall, with the CMS approved and issued two new codes, one for a per member per month. So that would be a fee that would cover the full cost of the program for a person who is enrolled for a full month, and there are technical aspects about what that has to mean, and that would be 2040, which is for monthly billing. And for people who are actually in the process of engagement and or transitioning from the program that might not sort of meet the criteria for full months of participation, CMS issued this code H2041, which pays on an encounter basis, but the encounter basis reimbursement was calculated so as to cover the full cost of the program. What has happened since these codes were issued is the stimulation of work in states, principally around Medicaid, developing Medicaid financing. So the codes have done kind of what we wanted them to do, and that's stimulate activity to actually calculate the rates at which these services need to be reimbursed. And that's kind of where we're at right now. Monica, did I leave out anything important? Did I lose my voice?
No, no, you're good. And I suddenly realized that I had assumed someone else would be sharing slides and that it wouldn't be me. So I have now brought up our slides. So that people know these are the codes 2040 and 2041. You can bill against those codes today. And although David is talking about the Medicaid side of the world, in Massachusetts, we've consulted with Tri-West, who's a national consulting company, to calculate a specific rate for Massachusetts that can be used with both Medicaid and with commercial insurance. And so we are driving this, our MapNet little sub-financing group is driving conversations to get both sides to be fully financing and fully reimbursing coordinated specialty care, which leads us to the amazing work that Scott has been doing and really talking about Optum's interest as a commercial payer in paying for coordinated specialty care. You know, why are you pursuing it? What do you see the benefits are? And if you can, who are you talking to?
Sure, glad to. And I do want to say the caveat that we are paying for these codes, but with individual contracts. So it's not just a carte blanche. You can bill us for these codes right now. We need to enter negotiations and contract with providers before we start paying them. But having said that, we are very interested in promoting the use of these new codes. So Optum's been constantly trying to promote the use of evidence-based practices for behavioral health conditions wherever possible. We've identified coordinated specialty care programs as a well-researched and well-supported evidence-based practice that we'd really like to encourage. In looking at our own data, we realized that we've been paying for a portion of these services, but have not been paying for all of the components that make the service truly effective and evidence-based. We have been able to pay for medication management, psychotherapy services, the typical kind of fee-for-service codes, but we've not been able to pay, haven't had a mechanism to pay for the supportive services, vocational services, peer services that are such a vital component of coordinated specialty care. We also recognize that early intervention can prevent both short and long-term disability and utilization of services. So it's both the best thing for the member and the family, and it's ultimately cost effective. And that's in line with Optum's goals of providing effective, efficient care. And honestly, we see supporting this approach as a market advantage. So current and potential customers are always asking us what we are doing that is clinically innovative, that's in line with evidence-based practice. We want to be able to lead our competition in this area. And hopefully by leading, we will bring more providers and more payers into this market as well to cover these services.
That's awesome. Thanks very much for that explanation. I totally appreciate that Optum requires a negotiated contract in order to pay, but I would be remiss if I didn't share with this audience the general guidance on the national level that not paying for coordinated specialty care as a team-based rate is a parity violation. So I can tell you that personally in my work with health law advocates, we have sought reimbursement. It was actually for PACT under the HCPCS code and gotten money just by virtue of the fact that there is a billing code. To Scott's point, it's not as clean or as simple as for a provider to bill against the billing code without a contract. But please know that due to parity, you should be being paid, and the billing codes should help in forcing that conversation with some of the other carriers that might not be quite as forward-looking as Optum is right now. So thank you for that. And like the biggest takeaway from today should be you can be paid for everything you do. So Illinois, it was, as you said, David, a leader. You both have specific experiences with Illinois. There's been some pitfalls along the way. As the law passed in 2019, here we are in 2024, and I think they're still negotiating some of the contracts and have not actually got widespread coverage in spite of a legislative mandate. Can we talk a little bit about sort of what those barriers have been, what the challenges have been, and how we in Massachusetts might leapfrog over those problems?
Scott, you want to start talking maybe specifically about the negotiations with thresholds? I think it's important to sort of point out that at this point in time, one big provider in Illinois has negotiated with Optum and Blue Cross Blue Shield to establish this rate. And as far as we know, other CSC programs are not billing it at the moment. But I don't know, Scott, maybe you want to start with sort of how those negotiations went, and then I can then build out some of the other issues that I see around actually getting people to start billing this and getting insurance payments in place.
Sure. So the negotiations themselves went very well, very smoothly. We were able to come to an agreement on rates, on what our expectations were for the program, what thresholds expected of us. That all went very smoothly, but unfortunately, there's been a couple of barriers and issues that we've had to deal with. So the first is that, as you mentioned, David, this was put in place before the new CMS codes. So we used a one-off claim code to pay for the monthly service. And that has caused some issues in terms of claims payment. We're still kind of working through those issues and making sure that we're able to pay them cleanly. That it's whenever you do something one-off in such a large system as Optum is, unfortunately, that tends to create some difficulties in terms of a smooth process. The other thing that has really, frankly, surprised me is that we have not received that many referrals. So there have not been that many members of ours who've actually gone through the Thresholds program. And I think that's partly an awareness of on our side of making sure that our staff are referring to the Thresholds program, making sure that our commercial membership is aware that this is open and available to them. And I think it's also, just kind of the nature of the service and the location of thresholds and just getting a critical mass of members through. So we continue to try to promote the program, to try to make sure that our staff are aware of it, that we're referring members when we find them who are appropriate for the service, and continuing to try to work with thresholds to make sure that we remove any barriers people get in there.
That's great. And I really, as LaMonica said, we so appreciate Optum and Scott specifically for all the support that we've had. Having a commercial payer with us when we went to CMS was a big deal because it showed that it wasn't just sort of the public system narrowly writ that was requesting this. So I think one of the things we've learned, Monica, through our case study of Illinois is it's a big deal to get a commercial mandate. That's not an easy thing to do. And as you know, having now gone through 2 legislative sessions, I believe, in Massachusetts with a bill, it's important to realize it's a marathon and not a sprint, and that it does take some time to kind of address the issues and the kind of vested interests that people who are in this space possess. That being said, once one has the mandate, and I think this resonates with what Scott's saying as well, is it's really important for people to realize that they have access to this benefit, number one, because most people don't. And most people, it's my impression, who experience these kinds of problems probably go kind of a more conventional route in terms of probably going to their primary care clinician and perhaps getting a psychiatric referral, maybe having an inpatient stay, but without. So part of the issue is building a system that actually gets people into care quickly. And that requires public education and outreach and tailoring. And so that's one set of issues. And I think that will be one we're going to need to address on both sides, but the commercial side, perhaps, given what Scott's saying, particularly there, since this is an unusual benefit, I think, for people who ordinarily consider sort of their behavioral health benefits. The second issue is an interesting one, and that is that these programs, because the federal government put about $100 million of new money into the block grant, and then has supplemented that with some of the work the funds associated with the ARPA and other post-COVID kinds of programs or initiatives. So we've had phenomenal growth, not nearly enough, but we're up to over 300 programs nationally, and those programs have been funded traditionally, and this is changing, of course, that's why we're working on this project, but they've been funded traditionally with a mixture of block grant funds, fee-for-service funds, principally from Medicaid. So you've built, like Scott was saying, you can bill for psychotherapy, you can bill for medication management, depending upon the Medicaid program. But we know that from two studies, one done in New York and one done in Ohio, that covers about half of the cost of the program, the fee-for-service billing. And so the other half is covered by state, local, and block grant funds, federal block grant funds. That's not a sustainable model in the long term. It's really, really important that we have an insurance benefit. One of the things that I think we're coming to realize is that programs that have been grant funded might be reticent to start to develop revenue streams that require insurance billing. And part of that is because of the complexities of insurance billing and being on panels and all the other things that are part of a managed care environment, which we oftentimes operate in. But part of it is kind of what Scott was saying in terms of developing the infrastructure to do it. And, this is something that we've seen when we talk to Washington State, is there was a fair amount of infrastructure that needed to be put in place to actually just do this billing, and that at the state level, that could be a challenge, but it's evidently really a challenge at the program level. So what we're trying to do in Illinois, we'll discuss this we have a monthly financing meeting, which is directly behind this meeting, is what can we do to start to encourage kind of a culture change and to support this transition to an insurance-based service. As I think, as people know, these are conditions which affect young adults. And because of the Affordable Care Act, young adults are more likely to be on their parents' insurance than they were prior to the Affordable Care Act. And from the EpiNet program, that Dost and others participate in, we've learned that about 35% of people in the 100 or so clinics that are part of the EpiNet who reported their insurance status reported the fact that they had commercial insurance. So that's not a trivial part of what could potentially be this caseload. We're never going to meet the population needs in order to reach what would, the ultimate goal here is to really stem the tide of disability associated with these serious mental health conditions, unless we have an insurance benefit. So I don't know, Monica, did that sort of hit the high points you were thinking about there?
Yes, and I do want to highlight that one of our goals for this discussion, and we'll take questions in pretty soon. I see a couple of things coming into the chat, but is that culture change that needs to happen within the programs of understanding that not just that this is available, but it's going to help you grow your program, right? We're getting more money into the system in a couple of different ways, and therefore the reliance on how the block grant funds get distributed should become less and might be able to be repurposed to other things, which I will leave to Margaret to think about and decide. But if we can have both mass health and commercial insurance paying really what these programs cost for everything as a team-based rate, that includes, peer supports, that includes the time that people are that the multidisciplinary team is meeting to discuss the clients. It includes all of that time, and the leader of the Conversations from Threshold said that that was one of the things that was so critical to their conversations around the contract rate, because if you try to map it to the fee for service, then that's only the time that there is a clinician in front of a patient, whereas so much of the work that happens in CSC happens not necessarily with that person present, and often it's with much of the team present, and therefore having a team-based rate that covers really all your operating costs, that allows you to pay your staff members better than just a base living wage. And that's one of the things that we've discussed a lot in establishing the suggested rates for Massachusetts, is running through, what are real living wages here in Massachusetts, so that the providers who are on the team, be they peers, be they clinicians, be they case managers, are all getting appropriate salaries. So this is, like, it's a per member per month type of payment that allows you as a clinic, as a team, to decide how you are going to best meet the needs of the individuals in your care. So I can't emphasize that enough, that yes, it's a cultural transition. Yes, you may be giving up some types of funding that you've cobbled together, but the idea is to get you to a better place where it's a lot less work for you to get paid, and you can spend that time with your clients and not with billing codes or begging for money.
And Monica,
Yeah,
yeah,
go ahead, Scott.
Monica,
Yeah.
if I can kind of add on to this discussion about the payment, is that one of the reasons that we were very interested in the commercial side of this is that we found this kind of reverse disparity in which our commercial membership was being denied access to these programs because we would only pay a portion of it. And so that's one of the, I think, important aspects of this, is that we really do want to be able to support our commercial membership in going to CSC programs. And, I know what happens frequently is that when somebody first is diagnosed, one of the recommendations is to move them as quickly as possible onto Medicaid. And maybe this would allow commercial insurance to pay for those services through the age of 26, when they're no longer dependent on their family, or when they get their own commercial insurance. So we'd really, I think it's a good opportunity for the commercial side of the house, for the commercial membership, to get access to these programs.
Well, and as the parent of somebody who has schizophrenia and went through this push to go on to public assistance, to go on to Mass Health, I resisted that. I did not really understand that there might be more services available. It seemed like the wrong thing to do. He was on my insurance. Why shouldn't that insurance take care of him? So I think when we think about that, there's this whole population of people that it takes them years to get onto to the decision to go on to Medicaid, and those are years of not getting the care they need because commercial insurance up until now hasn't covered this. So how much I appreciate what Optum is doing, and I feel it very personally as a parent. I'm going to
Monica,
take. Yeah.
let me tag on just for a second, and then we'll get to questions, I guess.
Yes.
And that is, I had an interesting conversation with colleagues from a Western state recently about many people being reluctant to go onto Medicaid, or to go through the process that is required, because you have to essentially, we don't want to get into the details of what that requires, but generally you almost have to adopt an identity that says you're disabled and cannot work and can't, so in some sense, we're sending exactly the wrong message. And then I was kind of surprised to learn that there are people who don't want to be associated with government programs at all. For them, that's like welfare, and that's not, they won't go on welfare. That had never really crossed my mind, but I can understand it. So there are lots of reasons for getting a benefit that's available for everybody, whether they're on a public system or in a private commercial system.
That's absolutely right. And I can tell you that personally, it would have felt like a failure to provide for my child. So that's, there's all these sort of internal
Right.
conversations one has. So the
Right.
question that's been in the chat for a while, so, sorry, Kesh, is thank you for educating us about the team-based rate. How is coordinated specialty care defined for the purpose of being eligible for this rate? So I guess either one of you could take that question.
What we
I
did,
guess
I can
Scott,
say what we
yeah.
did when we, Kesh, when we put the application together. One of the things that has really made a difference in this space is the fact that the NIMH, the National Institute of Mental Health, wrote a paper defining coordinated specialty care. So Bob Heinsohn, Amy Goldstein, and Susan Azrin, and Bob worked on this pretty assiduously for several months, tried to go in and extract sort of the core elements of coordinated specialty care that that were compatible with the dominant models that were delivered. The Navigate model, which was part of the RAISE trial, and the STEP model at Yale, and the On Track New York and ESA and others. And he tried to sort of extract out of that sort of what a generic coordinated specialty care team consisted of. And so when we put the application together, we relied heavily on the work of the NIMH in terms of defining kind of this generic service. And so, it's got case management, it's got a prescriber, it's got a psychotherapist, it's got a supported employment education component. And I'm probably leaving something out, but it's that, all of us have seen this graphic where you have the person in the center and then you have the services kind of surrounding them. And those are the services that we detailed. So at the level of getting the code, that was adequate description of the program. One of the other issues that we're addressing is is there a certification process in place? And again, here I think as Massachusetts is a leader in this area, such that if someone calls themselves a coordinated specialty care program, they meet certain kinds of criteria, which one might think of as sort of the fidelity of the program, but if there's active conversation going on about this now. And that then gets into the nuts and bolts of what a program has to be in order to call itself that. And I think, Scott, we've got that same concern in some sense on the commercial side that we do on the public payer side, because if you create a code, people will bill it. And if you're paying for coordinated specialties, they'll say that's what they're providing. But how does the payer know that that's the case? So it's a long-winded way to say that we use the NIMH definition to get the codes. And now we're in the process in various states of trying to implement what exactly that means. Some states like New York and Washington State and others, anytime you mention states, you're always going to leave people out, which is a terrible thing to do. Have some of these processes in place. Others have them work underway to develop them. So I don't know, Kesh, if that's
Yeah,
adequate.
thank you very much. That's very helpful. The reason I asked that question is when we looked at the literature some time ago, the way coordinated specialty care is defined around the world is highly variable. And some elements get into some models, some therapeutic elements are not there in some others. This is always a moving target as our state of knowledge about how we treat people in the early course of psychosis evolves. So, for example, the NIMH model did not include peer support, for example.
Exactly right.
Did
Exactly
not
right.
include substance abuse counseling, for example, or cognitive remediation, and so on. They're all, important aspects. So, if there is some level of flexibility built into how CSC is defined, that might be helpful for the field.
And
Yeah,
Kesh,
and I'll say that when we, oh, I'm sorry, David.
No. Well, I just in response to that, there's work underway by Bob Heinsohn and others to kind of update that paper to talk about some of the things that have emerged. That was unbelievably, Kesh. That was 2014 when the paper was released.
Right.
10 years ago. I may have even had some color in my hair 10 years ago. I may not have, but it's been a while. And so, and I think Bob, don't hold me to this, but I think Bob is working on trying to update it. Scott, I'm sorry I stepped on you.
No, that's fine. I was just going to say that what you outlined, the NIMH standards, that's really what we look for when we look for programs to contract with. And we look for those elements, you know, ideally if somebody's in the EpiNet program or listed on the SAMHSA locator, that's definitely a good step. But really we would look at what are the specific services and do they line up with the NIMH standards.
And I would point out that MapNet does the fidelity assessments of all the programs here in Massachusetts. I think that would get used. And in the legislation that David mentioned that did not pass, we talked about just meeting accepted standards of care, and that we definitely did have a couple of those standards listed. But to your point, like when we were writing the legislation, one of the things we wanted was to give the appropriate flexibility to the programs. So it's a delicate balance between enough flexibility for teams to be creative about how they meet the needs of the folks in their program versus ensuring high quality and not expecting insurers to, you know, pay for crap. So we have to do that, but flexibility is a hallmark of coordinated specialty care. So I think many of us are, you know, looking for ways to strike that balance between assuring quality and providing room for flexibility.
Thank you.
Julie has a long question. Julie, would you want to come off mute and ask your question?
There we go. Sure. Hi, I'm Julie McCarthy, and I wanted to ask a little bit about the individual billing code. I'm sorry, I'm not looking at the correct camera. So for the billing code that could be used as people are ramping up or tapering off of full team-based services, would this potentially cover for the individual encounter, individual meetings with family members of loved ones who are trying to maybe connect their person with lived experience in their life with psychosis to treatment services or peer support services, even if the person with the lived experience with psychosis isn't ready to fully engage. And I'm coming at this from the perspective of working with a lot of family members in this space through research, through philanthropy funds. And one of the questions that comes up is how could we make this type of work sustainable? Because I think that families are very interested in trying to get the tools to help support their loved ones. And then clearly, as we've just heard from the Lived Experience Committee, when treatment engagement is done in such a way that is perceived as coercive, it can really lead to perhaps worse outcomes or the reluctance to engage in those services subsequently. So any potential for providing some of that support to families in an insurance-based way at the front end?
I know our strong preference is really paying for the monthly rate. So we would, and the way we have this currently structured is that we have would like to be able to pay two different levels of service. So there's the more intensive initial component where we'd be paying obviously a higher rate for more services, and then eventually there'd be a step down component where, you know, the payment would reduce and the services would also be reduced. And really the idea behind this would be that, you know, we recognize that, you know, not every person will have the same experience in a program. So there may be some who, like you say, are a little bit harder to engage. You may have to work more with the family. You may have to suspend services for a while. And so we would be paying potentially more for less services at that point. But then there may be another person that needs more services, is more engaged, and you're providing more than the average amount. So over time, it really should average out to be the monthly payment rate that we've negotiated. In terms of kind of what you're speaking about, like individual family services, you know, we do have the ability to do the encounter code, the H2041. We really have not had much experience with that. So my concern is that, again, the way we would be making or setting the rates or would be looking at this would be to kind of average the amount of a monthly payment and then, you know, break that into chunks basically. And I think since the services are provided by a wide range of providers, that one encounter rate may be lower than you would expect. And so I think that would be something that would be a little bit of a challenge for us to come to an agreement on what a good rate for that particular service would be. So again, I think what would be better or more sustainable for coordinated specialty care program is to have that monthly rate. Then you can plan and know what the income would be over the course of several months, rather than having that per encounter rate.
Thank you so much.
Julie, let me complicate things maybe a little bit. The idea of an encounter rate is to take the overall cost of delivering the program and divide that by the number of encounters that occur, so that if you build everything on an encounter basis, it would cover the full cost of the program. So that's kind of the gold standard that we're working toward. Your question's a very good one, in that an important part of coordinated specialty care programming is outreach and engagement. And the process you're talking about, working with family members, could be part of an engagement strategy for a person who's having difficulty kind of figuring out what's going on in his or her life, and is not wanting to adopt the identity of a person with a significant mental illness. That's a really good question, and I don't think we have an answer for that quite yet. My guess would be, within an insurance model, there is a beneficiary, and whether or not the family, and Scott may know a little bit more about this, whether or not the family could be defined as a beneficiary and receive services, or whether the services have to be specific for the person who is not enrolled in the program, from my perspective, are open questions. So if somebody's being engaged, they're not enrolled yet, we have to cover the cost of engagement. Working with families could obviously be a really important part of that. So I think, Monica, you didn't say that people are going to be asking these like really good questions when you roped us into this. That's a great question, Julie. And I think that the devil are in the details of actually putting these things together. We should pay for that, absolutely. Whether or not within the insurance world that focuses on a particular beneficiary we can is another question, but it's a great question.
So I'll say that during the Tri-West engagement with Massachusetts, they actually came up with an encounter rate, and I honestly don't recall what that was. I also don't recall the metric, but they were saying that a certain number of encounters meant then you tipped over into the monthly. I think it might have been 3, that if you had more than 3 in a month, but don't quote me on that, but there is a number. And then you tip over into the per member per month for exactly the reasons that Scott described, which is it's really a better way to meet the needs of the person and their family. And David, I'd suggest that maybe this question that Julie brought up about what happens during some of these periods where the individual is not the primary center of attention in that moment, what happens with coordinated specialty care and financing might be a great topic for a future PEPNet call, because I'm sure that Massachusetts is not the only state with that kind of a question.
Agreed.
Do we have more audience questions? Okay, guess not. I guess there was one other thing that we were hoping to have time to share, which is not quite off the presses yet, but there is a report coming out, right, from McKinsey that maybe you could share with everybody sort of what that's about, when we might expect it, and why it matters.
I have a quick question. Sorry to take us back. That's sort of connected to, I think, Julie's question. And I was thinking about like the upfront component of services that is around, and like is around care coordination, which I know was sort of mentioned as one of the elements, but this very particular component of care coordination when patients are in a hospital, and the best care is always that they're asking either the outpatient team that sends somebody in, or that is going to be the new team, can you meet with the hospital team? Can you have some coherent, warm handoff from the people doing the acute care so that they don't get rehospitalized, so that the formulation and the conceptualization of the person that you're working with is like fluent into the next level of service. And only one person can bill if someone's in a hospital. And like, that is like actually such a time-consuming multi-provider element that is sometimes before you fully establish care with a patient too. So I just wanted to like highlight that as something that I think is related to what Julie was describing, because it can be family members, but it also can be providers from other services before you even meet.
Well, I think that's,
Actually,
again,
before I
that's
let you answer that,
Oh,
Scott, I'm going to
okay.
say something
Sure.
that maybe will queue up an idea for Optum, which is, I don't know if folks are aware, but Mass Health has recently issued proposed regulations for covering PACT for all Mass Health clients. And as part of that, they actually talk about this inpatient moment. And I ended up with a colleague doing some research about this. And New Jersey has the concept of in-reach instead of outreach, in-reach. When a client is in the hospital, they actually do continue to pay PACT for the PACT team to coordinate with the hospital. So, Scott, I would encourage Optum to possibly consider an in-reach program for coordinated specialty care, because I couldn't see who was asking the question, but it was a great question, and it really is important for continuity of care.
Yeah, absolutely. Duly noted, Monica. We will consider that. The other comment I was going to make, though, is that, you know, I think that's another advantage to having this monthly payment arrangement, is that if a member is if somebody's in the hospital, person's in the hospital for a week or so, you know, you would continue to get the monthly payment, and that would be considered part of the service that you're providing, is that coordination of care and step down and all that work. So again, that would really be another reason to work around a monthly payment.
Yeah, I was
And
gonna echo that. This is Kelsey, and was involved with Monica and the folks who are setting the rates, and they did really leave space in that for, I think, this broad category of that non-patient facing administration work, and that includes outreach, inreach, whatever we're calling it, but that should all be built into that team rate.
And Jessica, if you think about calculating the entire cost of the program, you disappeared on me. There you are. That the activities that are involved in doing that in-reach sort of are part of the overall cost of the program, and should be in that monthly or encounter rate conceptually. Practically, there are rules. You know, all of us children got rules, and some of the rules are about who can bill what when somebody's in an institutional setting, and so those have to be addressed. It sounds like from what Kelsey said, they were considered appropriately in Massachusetts, but that's important, you know, because we want to maximize continuity of meaningful care. Yeah, and not Also, I feel, Jessica, like you and I are related, because about half the time I'm called Stern for some reason. So rather than I know. Generally David Stern.
Well, that's a common last name. A lot of people ask me all the time, actually, if I'm related to someone, but usually not. I think I appreciate what you're saying, and I also want to make sure we're thinking about it in two ways. Like, patients that are already established with the program, it's like, to think of them within the monthly rate makes a lot of sense. But for people that are not yet, they're not yet like enrolled patients. And I think like, so I'm a medical director in a community mental health agency and at the CEDAR program. And so one of the things we're always working on is like, well, did they register yet? Are they our patient yet? Right? When we're getting frantic, understandably high volume and time intensive calls, right, from the hospitals and the parents. And these are calls that actually not like it's not just intake that can answer those calls. Like, we need specialists answering some of those calls and doing the connection to the handoff. And it's a gray zone of like, well, whose patient is it yet if they haven't registered? And we all know that people don't always get to their first appointment, right? And like, that's
We're
a
gonna,
complicated thing. So
I'm sorry, I'm gonna have to cut you off because we're actually a minute over time.
That's right.
So,
Really?
and I know I so appreciate having such a large audience on the very last hour of a 2-day conference. So thank you all for being here. And a million thanks to Scott and David, who have been wonderful partners in preparing for this and in doing all this work, and have been leaders across the country in getting commercial insurance and Medicaid coverage for coordinated specialty care as a team-based rate. I can't thank you enough.
Thank you to all three of you for this great presentation.
Thank you.
A round of applause. And I'm going to now turn it over to Dr. Macheri Keshavan to provide some concluding remarks. That's going to wrap up the 2-day Mass Step conference. Go ahead, Kesh.
Thank you, Dost. That was indeed a highly enriching experience the last 2 days, and the fact that almost everyone stayed on till the very end speaks to how engaging and useful and practical what we learned from every one of the speakers and the panelists. So it's hard to summarize, all those important insights from the 2 days. But as from the previous years, what we have done is to summarize in no more than about 5 to 10 minutes the key highlights for the purpose of those who are still in the meeting, but also those who might have missed some parts of the meeting or have missed yesterday and so on. So if I think about what are the key things that we learned, there are 4 things that come to my mind. In terms of early intervention in psychosis, we need to know, how can we do better from what we already know? That's question number 1. Question number 2 is, how do we get to know better what to do? Question number 3 is, how do we do well? How do we want to do better, equitably and inclusively for those who we serve? And finally, how are we going to pay for what we do? So those are the 4 key questions that were covered in this conference. First of all, how can we do better from what we already know? This is the whole idea of implementation science. And Jay Shaw yesterday really exemplified some key principles of this learning health system approach, where the data is the king. We need to utilize what we are acquiring in terms of our real world experience and translate that to improving outcomes in an ongoing way. It's a kind of an engine of this learning health system for which the data are the fuel. Now, he also pointed out in one of his slides that while early intervention in psychosis has made major advances in the past few years, if you really look at the trajectories of these illnesses, the curve is still not bending. There are a number of individuals who continue to not do so well down the road. How can we improve outcomes in the longer run and not just the shorter run? So for that, one needs to understand the disease processes better. And studies such as the AMP initiative that Carlos Larrauri this morning very elegantly reviewed point to the importance of understanding the very roots of this illness as they begin in the prodromal phase and find ways of developing innovative interventions, and not only to find ways of predicting who will get better with what kind of interventions, but also have markers that tell us where we need to be going in terms of developing novel interventions. And then in terms of the question of how can we do better equitably and inclusively for the populations that we serve. Sean Davis from the NIMH very comprehensively pointed out the powerful impact of social determinants of health, including what color of people we serve, various aspects of minority communities. And he pointed out how outcomes are unfortunately not as good in those minority communities compared to the non-minority communities. And the important finding he pointed out is that one of the major factors that predicts outcome in psychosis, namely the duration of untreated illness, DUP, or treatment delay as we call it, is powerfully impacted by factors such as migration and ethnicity and other social determinant factors and so forth. And these are key issues to be addressed in how we think about improving our services and the outcomes as we go forward. And finally, just prior to this, we heard Monica Luke and Scott Birchley and David Shern give us a very insightful overview of some exciting developments in paying for care, having a team-based care, which is now a reality. This is the power of this kind of a conference. Just 3 years ago, when we had this meeting, Ken Duckworth had raised the question how nice it would be if we had a team-based rate for ugly course psychosis. Now it looks like it is becoming increasingly a reality, even though there are still issues of parity and also how we define those who get such services and how such payments can be continued in an equitable way going forward. Finally, some thoughts about where we go forward. So one of the important things about this conference is, which we look forward to the whole year as we end up to this day in November, is we get a marching orders, so to speak, from everyone who cares for this field of work as to what should we be doing as our next steps. We need to prioritize. I think there was a point in the chat by Megan Good. She said, how do we prioritize? What are the areas where there is more need for research? Perhaps we should get that kind of an input from our community of those with lived experience, as well as the community of treatment providers and researchers. Clearly there are some important aspects like social determinants of health we need to understand better. We still do not understand the biological basis for the course of the illness and why some individuals have a more chronic illness and some progression, and that is an important unmet need. The other important goal forward is the very powerful insights that came from the lived experience community that Vera Suarez led, that points to the powerful effects of the illness and how society treats it as experienced by individuals with the illness in terms of the loss of autonomy and perceived discrimination. That we really need to become aware of, all of us providers, and listen to the voices of people that experience the illness. So that brings me to the point that going forward, again, taking a leaf from what Sean Davis pointed out, to address the aspects of the roadblocks to good outcomes, we need to look into what are the roadblocks for access to care, pathways to care, and engagement in services, and retention of individuals in care in an ongoing way. And we need to address disparities that relate to that. Finally, I was very touched by the one thing that Locke said. He said, someone pointed out that if depression is a common cold, you have cancer. And this is really a statement that whoever said that, the provider that would have said that, must be operating entirely out of ignorance, because the illnesses are very, very variable, number one. And number two, many of them do get better with good treatment and how we provide care for them. Using these kinds of analogies is doing a great disservice to our people that we serve. We need to have a language of optimism. Language is very, very important, and we need to have language of hope. So I think that in my quick 5 minutes summarizes a few highlights of what we learned over the last few days. And thank you all for participating. And thanks to all of you who have helped make this conference a success. And look forward to seeing you all next year.